like you. We can come together until you see me. Singing, I've got the answers to your problems. Singing, if you allow me, we can solve them. There's more to me than you see. I have hopes, I have dreams, I have vision. Just like any other person in this whole wide world, I want the chance to be, but you must see me. Can't you see me? The color of my skin, to see that I am just like you. Can't you hear beyond the words that I say, to hear that I have dreams too? Until we see me, hear beyond, face the truth, and I'm just like you. We can come together until you see me. Can't you see me? The color of my skin, to see that I am just like you. Can't you hear beyond the words that I say, to hear that I have dreams too? Until we see me, hear beyond, face the truth, and I'm just like you. We can come together until you see me. We can come together until you see me. We can come together until you see me. We can come together until you see me.
Good morning and welcome to the inaugural Health Equity Series. My name is Stephanie Harris and I'm a member of the Board of Directors of the Ohio Federation for Health Equity and Social Justice. We are excited to present this first segment of the series titled Promoting Health Equity in Communities of Color. We hope that the information shared today will help to inform and guide you as we journey together in an effort to reduce and ultimately eliminate disparities. Like many of you on this webinar, the Federation views disparities in health as a social justice issue. Considering this, we have assembled an impressive panel of individuals who are internationally and nationally recognized experts to share their insights. As part of my duties today, I want to share a few housekeeping tips. If you have questions, please ask them in the chat box. I mean, we've all learned to do that in the world of Zoom. Our moderator will attempt to ensure that all panelists receive your questions. Due to some time constraints, all questions may not be answered during the session, but the Federation will post questions and answers on the Federation's website. The website will be listed in the chat box. We're also asking that you complete the evaluation, which will be sent by email after today's session. Finally, I would like to recognize and thank our very, very valuable sponsors. Our gold sponsor, Amgen, bronze sponsors, Health Path Foundation, the Lilly Corporation, Takeda Oncology. Our sponsor, Global Healthy Living Foundation. It is now my pleasure to present our panel moderator and first presenter, Dr. Cara James. Welcome, Dr. James.
Thank you so much, Stephanie. It is a pleasure to be here on this inaugural conversation around health equity. And I am so thrilled to be joined by a couple of my colleagues who I've known for a long time, Brian Smedley and Winston Wong. And our plan for today is we wanted to start off in framing the conversation around health equity and talking about how we kind of got to this place and where we are, and then moving forward with some perspectives from each of our other panelists, and we'll be joined as well by Andrés González, who will also provide his perspective. And so to begin with, I am going to apologize because there's somebody behind me who is hawking the window. So if you hear some noise, I apologize for that. But wanted to start as well by framing a little bit of our discussion for today, and that's something that'll kick us off. So I'm going to share slides and hopefully. Okay, so hopefully you are seeing the slides. And just briefly, I am the president and CEO of Grantmakers in Health, and we are an organization that works with nearly 240 foundations and corporate giving programs to achieve better health through better philanthropy. We work across the country with organizations large and small and focus in our 12 areas of health. And then we are fortunate to have Dr. Wong as one of our board members. And in this moment, clearly we are as a country in a moment where we have really woken up to the disparities, particularly racial and ethnic disparities that have been highlighted by COVID. There are too many to name in the time that we have, but just some of the ones that we have seen are disparities in COVID cases and hospitalizations and mortality, access to personal protective equipment, nursing home deaths, the location in some cases of testing facilities, who are the essential workers and what have been their abilities to work at home and have that flexibility, who's been most affected in the job losses and in terms of the economy, food insecurity, and our children's participation in virtual education. Throughout our society, we have inequities, and I think in COVID has touched on every aspect of those. And it's worth taking a step back just to kind of look at where we were before COVID, because these are not things that are new. They have existed throughout our society and throughout time. And unfortunately, our disparities in race and ethnicity start at birth, and you can see We have a higher infant mortality rate for Black women, as well as American Indian and Alaska Native women compared to other populations. We live sicker, and you see in terms of fair poor health that communities of color, particularly those who are Native Hawaiian and other Pacific Islander, have higher rates of reporting that their health is fair or poor, and have challenges accessing healthcare. And so you can see nearly 60% of American Indians and Alaska Natives use the ER or a clinic as their usual source of care, which has implications obviously for getting screened early, preventive service treatment, and other continuity of care issues. And when we total the sum of what we've seen, we've had a large focus on improving the quality of care in our country, and we have done so, but we have not seen a similar reduction in disparities overall. And these data come from our National Healthcare Disparities and National Healthcare Quality Report, which has been produced annually since 2002 from the Agency for Healthcare Research and Quality. And that middle blue bar tells you that the overwhelming number of disparities that we have remained the same throughout the nearly 20 years that we have been tracking this. So while quality has improved, we have not reduced disparities and need to be more intentional in our focus on them. One of the other things that's really important to know, of course, is where you live matters. And as we talk about, what's happening across the country and looking in localities and counties, this just shows an example of some of the disparities that we see at a county level. In this particular one, I'm showing Black-white Medicare diabetes disparities, so the prevalence of Medicare diabetes among Medicare beneficiaries. The darker blue counties represent those in which the disparity is greater by 15 percentage points or more. And the ones that have the stripes indicate some of our urban counties. So I just picked out Cuyahoga County, where Cleveland is, and you can see that Black Medicare beneficiaries, about 32% of them have diabetes compared to 22% of white Medicare beneficiaries. And in some cases, one of the challenges that we have with regards to understanding where we are with disparities is data. And those gray counties are the ones for which we don't have enough data to be able to report what's happening in those communities by race and ethnicity. So where you live matters. We have disparities starting at birth that continue throughout the life course, challenges accessing care. And while quality of care has improved, we still see that communities of color have challenges in terms of the disparities that they experience. And one thing I want to note is that not all disparities are ones in which communities of color are faring worse. And as an example, when we look at this is actually fair or poor health, but when we think about, for example, suicide, that's one, and opioids, in which we have seen higher rates for those who are non-Hispanic white. And we know that people live at the intersection of many characteristics. And so this is one in just looking at fair or poor health in rural communities. And you can see that, again, communities of color in those rural areas fare worse in terms of their health outcomes. So we talk a lot about racial and ethnic disparities. And I want to just note that when we're talking about equity, we're thinking about people across a variety of demographic characteristics. And some of the disparities that we see, we talk most commonly about race and ethnicity, but there are also those by sex, socioeconomic status, disability, geography, and sexual orientation, and gender status, just to name a few. And the drivers of those disparities are things that we call the social determinants of health. And this is from Healthy People in terms of what they look at for those social determinants of health: economic stability, education, social and community context, health and healthcare, as well as the neighborhood and built environment. And just to highlight very quickly how that plays out, in which we look at some of the structural factors, policies, and programs that disproportionately have an impact on these social determinants of health and the way that they play out for different populations in terms of race and ethnicity. I think the one that everyone understands is income. And so when we look at income, we can see that for Black and Hispanic communities, 1/3 of Black and about 1/4 of the Hispanic community has an income below $25,000, compared to, at the other end of the spectrum, 45% of Asians and 34% of non-Hispanic whites who have an income of 100,000 or more. And again, noting one of the challenges when we do disparities work, we don't have good income data for American Indians and Alaska Natives, and we aren't being able to look at, in this case, data for Native Hawaiians and other Pacific Islanders. So we still have some challenges in understanding what's happening. And these, again, play out throughout the life course, where we know that 1 in 5, for example, Black children are living in poverty. And at the other end of the life course, when we look at the median per capita savings for our Medicare beneficiaries, we see that for white Medicare beneficiaries, the median is 118,000 roughly, compared to 14,500 and about 10,000 for Hispanic beneficiaries. And when we think about what that means for your ability to age at home, to age in place, and to be healthy along life and age, there are challenges. So it's not surprising that we see nursing home populations for Black who are younger and sicker compared to others. And of course, health coverage really matters. So we see here for the type of coverage as well as the lack of coverage matters. 73 and 3/4 basically of white and Asian Americans have coverage that is through private coverage. And you see for those who are Hispanic and American Indian, Alaska Native, as well as African American, a greater reliance on public coverage through Medicaid. And for our American Indians and Alaska Native and Hispanics, a higher proportion of those who are without coverage and uninsured. So what does it take to achieve health equity? Well, one, as we have seen in this moment, everybody's talking about it, but we're not all talking about the same thing. So I want to just kind of ground us in a conversation and definition of what health equity means. For healthy people, it's defined as the attainment of the highest level of health for all people. And a very commonly used definition from the Robert Wood Johnson Foundation is that health equity means everyone has a fair and just opportunity to be as healthy as possible. Practically, what that means is that we're reducing and eliminating disparities in health and its determinants and the adversely affected or excluded marginalized populations. And when we think about what that looks like in practice, it's not giving everyone the same thing, but giving people what they need to be healthy. And so this is one example. You may have seen the one of individuals at a baseball game with different boxes that's commonly used. But again, the main point is we're giving people what they need to be healthy and not giving everyone the same thing. And when we think about it, we need to be thinking about these solutions at every level of our socioecological model. So thinking from policy on down to the individuals and the organizations and communities that they live in. And what we've seen in this past year and a half with the pandemic is that within the space of philanthropy, it's not unique. I think business and others have done similar, where we've had people who've issued statements, provided additional support for grantees who are led by people of color, as well as the establishment of health equity and racial justice initiatives, hiring of those individuals to lead diversity and inclusion, equity and inclusion opportunities within organizations, as well as developing strategic plans for that focus on health equity. And we still have a number of people who are figuring out what they want to do and what they can do. The conversations around health equity have changed a little in the pandemic, and we see a lot of focus on the data. We just had the recommendations from the White House Advisory Committee on Health Equity and Data that just came out a week and a half ago. We've seen a focus on quality of care and how we can infuse an equity lens into value-based payments, continued effort on the social determinants of health, focus on workforce diversity, a lot of telehealth and broadband to make sure we're connecting people in rural communities and others, as well as the public health infrastructure, move towards more community engagement and power sharing, a lot of attention on the American Rescue Plan Act and other dollars that are coming into the community, and finally, conversations around structural discrimination. What we're not hearing as much of is kind of this, sort of distinction of some of the social determinants of health and health equity. I think before the pandemic, we had a little bit of a conflation of these two ideas, and that if we focused on poverty, for example, or income, then we didn't necessarily have to look at race and ethnicity. And I think our country's history shows that they're part and parcel. So going back to that definition of eliminating disparities in those drivers of health that adversely affect marginalized populations, it's both and. You have to look at race and ethnicity as well as those social drivers of health. I think we need to talk more about what's happening in our tribal communities. That continues to be something we don't focus on, and there are real challenges there. And I've been struck by the focus on burnout and other public health workers who are leaving the workforce, and yet we haven't really seen the national conversation around workforce development and what those needs are. And I think we have some real challenges as we look ahead, as well as those longer term issues, because we can't diversify our workforce if we can't get college graduation rates for communities of color above 24%. And then we have a lot of people who are in health equity at the moment, and we hope they will stay long term and get into this space and really dig into the work, because the problems that we are seeing are not those that'll be addressed in a 30, 60, 90-day plan, but things that really are going to take a long time and a long focus and significant resources. And so this is a window of opportunity, but we want to make the most of it and hope that people will stay and commit to the long-term work that we need. Again, tribal health really important, so apparently I put that twice. And then also talking about immigrant and refugee health. We've seen a lot of challenges and are with that and continuing to focus on that, but need to do more. And lastly, I would just say accessibility of services and thinking about individuals with disabilities and making sure that we are continuing to push on the activities there. So what do we need to do? Continue making health equity a priority, strengthening the role of leadership, engaging communities through humble inquiry, knowing that they know what their challenges are, have solutions that can be brought forth, and we should work with them as partners. We need to strengthen our data infrastructure and analysis. We have 22 states for whom their Medicaid race and ethnicity data is highly concerning or unusable, which makes it very hard to know where we have disparities. And we have to tackle those tough issues, those social drivers of health and some of the structural issues that are leading to inequities, and make health equity part of our standard operating procedures. So it's not something that is just a passing fad, but just the way that we do business. And finally, create programs and policy sustainability and develop a robust pipeline. So we have a lot of work ahead, and I'm really excited that we have 3 great panelists who will talk us through that, and look forward to your questions and engagement in the discussion. Please chat those in, and we'll incorporate those once we have finished with our presentations. But I'm going to turn it over to Dr. Andrés González to kick us off. Andrés?
Wonderful. Well, thank you so much, Dr. James. That was actually a great overview. Thank you so much for the invitation. And so I want to thank Ron and the Ohio Federation for Health Equity and Social Justice for this opportunity. I will be coming in certainly from a Hispanic Latino perspective this morning. So hopefully all of you will be able here to gain a little bit more insight and perspective on our Hispanic Latino community. And what I will do here is, oh, good. Can everyone see my screen, by the way? Just give me thumbs up. All right, wonderful. So what I'm going to do is I'm going to layer in some of the efforts or the responses that our integrated healthcare system here in the greater Milwaukee area, which, by the way, I work for Froedtert Health. That's the integrated health network here, has done in terms of our own health equity journey, and certainly the response during this triple crisis as well. So looking at the pandemic, as Dr. James alluded to earlier, certainly also layering in that economic impact in our communities of color, and certainly also the community unrest and racism that we have seen. But probably I should start with one of the key questions that I get constantly, which is, what is Hispanic, or how do you define Hispanic versus Latino? So the term here, and so I'm giving you how the Office of Management and Budget has defined the term Hispanic, is a person of Cuban, Mexican, Puerto Rican, South or Central American, or Spanish culture or origin, regardless of race. And that is important because we know that the federal government certainly has been in the forefront in terms of categorizing a group of individuals that, by the way, like any other group, we're not monolithic. So how do you then capture who we are as individuals? And so that's the term Hispanic. The term Latino, on the other hand, really refers far more to the lived experiences that we have geographically. So under Hispanic, there's about 21 countries. Under Latino, we add about 5 more. So think about, for example, Brazil and the French Guiana in South America. Those actually, while they might not speak Spanish, they actually are of Latino descent, and certainly they live within the geographies that I have alluded to. So that's a little bit of the difference there between those two terms. I will be using the terms interchangeably here, or we'll be using Hispanic, Latino, referring probably far more to those terms. A couple of other things that I think are important here. From a federal government standpoint, the categories that are used are Hispanic or Latino, or non-Hispanic or Latino. And I think, again, that's important to recognize here, knowing as well that many of us, by the way, might not actually subscribe to either one of those terms. I will tell you personally, I go by my ethnicity, which is of Puerto Rican. I'm Puerto Rican, so I identify as a Puerto Rican individual, not necessarily by Hispanic or Latino. So to me, those two terms, while I understand the significance of it, it's not, those are terms that I perhaps do not identify. But I think it's important to understand that. One more point here from a data collection standpoint is that none of our federal government agencies were created equal. And so you have on the left-hand side the CDC, and they do Hispanic, non-Hispanic, and other, versus on the right-hand side, which probably, by the way, the U.S. Census Bureau has probably the most detailed, definitely designations here or categories for our Hispanic, Latino. And so you can see here the difference where then they actually break that down even farther out. From a landscape perspective in the U.S., and this is actually a great visual here, you will see that there's actually 6 states, that already certainly have a 25% or higher significant community that happens to be Hispanic or Latino. Again, a lot of this is self-reported, and we're going to get into that issue later on here. And then, of course, Puerto Rico being also a territory of the United States as well. So I think it gives you a little bit of a perspective here, or landscape of where do the Hispanic Latinos actually live throughout the U.S. here. So again, seeing that increase throughout the U.S. From a breakdown perspective, I wanted to actually give you a little bit of that flavor. Mexican Americans continue to be the largest percentage in the US, is about 63.4%. Puerto Rican would be certainly the second largest, and then you see there some of the other spread. All in all, it's about 60.6 million, Hispanic Latinos in the U.S. And I say that with a little bit of trepidation because we all know that that's actually a lot of the data that is reported through the U.S. Census Bureau, and we know that we have a lot of undocumented individuals that might not certainly want to or feel free to actually provide that information freely. So there's always a delta in terms of how many Hispanic or Latinos we have in the US. So what are some of the indicators that come into play? So here's a few of them that I just wanted to certainly share with you. One of them is country of origin. Another one is the place or country of birth. Those are important because I might be born here as my children are. They were actually born, so they are U.S. citizens, but their parents are of Puerto Rican heritage, right? Or we were born in the island. So certainly, while they identify as Hispanic, Latinos, or Puerto Rican primarily, they're actually are also U.S. citizens, and that comes into play for many, especially from a generational standpoint here. Citizenship as well, as I mentioned earlier, language. Many of us, even if we grew up here, which is my case, I still actually prefer to speak in my own native language of Spanish. Actually, when I access care, I prefer to actually go to a bilingual bicultural provider to be able to actually fully connect in my own language. Race, we talked a little bit about that, the importance of that, and then culture, as well as assimilation versus acculturation. And these actually are important key drivers because this will actually have a profound impact on individuals' ability to either have access or the level of care, perhaps, that they might actually get as they access care within one of our facilities or healthcare systems. Shifting here a little bit about disparities, and again, Dr. James framed this extremely well. You will see that I put here 4 quadrants. Certainly, I could have actually listed a number of other ones, but I wanted to give you a little bit of a flavor for what are some of the issues that our Hispanic Latino community actually faces. And so what you will see here is diabetes and cardiovascular disease are 2 of the main drivers there. We will see actually, and you can see that from literature, and I can confirm that based on our system here in the greater Milwaukee area, that Hispanics are 1.3 times more likely than non-Hispanics to die from diabetes. A lot of that, right? I mean, a lot of those contributing factors are whether it's actually my diet, of course, plays a role there. Whether I'm actually insured or uninsured, that's actually will have a profound impact on my ability to actually, manage my diabetes, perhaps, or prevent it for that matter. And certainly, there's a number of other drivers as well, whether, I live in a community, and Dr. James mentioned that the importance of zip code probably matters more than genetic code. And we know that we have a number of our Hispanic Latino communities throughout the US that would be health deserts. They do not have facilities that are medical homes within our community. So the access perhaps might not be there. So that's some of the contributing factors there. You can see here that cardiovascular disease will be another one. And what's interesting about cardiovascular disease is that we see that Hispanics are lowering the death rate from heart disease than non-Hispanic whites. But when you look at those Hispanics where we have a largest percentage, where there's a predominant percentage of Hispanics within that community, we tend to see higher percentages of cardiovascular disease. And again, some of those contributing factors per the literature could be the health deserts. It could be, again, food and nutritional, right, our diet. It could be also other issues as well, including citizenship, whether I'm actually certainly whether I am a U.S. citizen or whether I might not be, so whether I'm documented or not. And so those come into play greatly here, and we have seen that being an issue here in the greater Milwaukee area. Obesity as well continues to be an issue within our community. As you can see here, among Hispanic American women, 78.8% are overweight or obese as compared to 64% of non-Hispanic. What's interesting is in 2018, Hispanic Americans were 1.0 times more likely to be obese than non-Hispanic whites. We know that our diet certainly becomes a major driver in these discussions. And then asthma, of course, within our children, especially within our children population, 40% more likely to die from asthma than non-Hispanic children, and nearly 10% of Latino children under the age of 18 suffer from this chronic illness. I will tell you that within the Hispanic Latino group, Puerto Rican children tend to have a much higher percentage of asthma than other groups. In terms of COVID, quickly here, I think that many of you might know this story, but as you look at Milwaukee, Milwaukee tends to be the second most segregated city in America by Brookings Institute. There was a report, and typically it ranks in the top 3. And so there's a number of issues that our communities of color confront here. And I think the pandemic uncovered or exposed those issues, as we know. And so one of the first stories that came out of the Milwaukee area was that especially our African-American males were losing their lives, and they were 3 times more likely to die due to the coronavirus. And so that was actually the first story that came out of Milwaukee. And I remember having a discussion with our CEO and a number of other executives, including our chief medical officer, and saying, what is Froedtert Health's role? What are we going to do differently and better, knowing that we have been down this particular equity, diversity, inclusion journey now for 11 years. And we'll see here in a second how we became proactive through those efforts. Obviously, our Hispanic Latino community on the South Side also was touched by that. And we, and certainly it was about 33%. So about a third of the community were impacted by COVID. And certainly we had also a death rate within that community that was much higher than the certainly the white community in our community. And so again, a lot of issues in terms of the pandemic. We also had issues around testing and having testing sites within walking distance of our communities of color. And then of course, the vaccination issues as well that I think many of us might be aware of. And certainly Milwaukee was not immune to that either, where even health systems like ours that decided to actually being very intentional about having vaccination clinics within the community, we started seeing people from the suburbs driving in and taking some of those spots that we had originally slated for our Hispanic Latino community or other communities of color. So we had to be super intentional there and certainly kind of work through those algorithms to certainly undo or certainly take into consideration some of those realities to ensure that then we were creating access to our diverse communities. A couple of things that we did here that were really important and impactful: COVID vaccine. We had a number of virtual town halls. This on the left-hand side was more internally focused for our staff, but we created a vaccine confidence effort within the organization. And then we took that out into the community, which is what you have on the right-hand side. What I will say about that is that really led to some crucial conversations, and to Dr. James' point, coming in with humility into the community and not prescriptive in our approach and really eliciting their feedback. So that really led to the co-creation of public service announcements that were culturally and also linguistically relevant for our communities of color. And that was actually a great way of meeting the needs of our community, but one in which we certainly elicited the feedback from the community, and they knew what some of those solutions were. So I think that this really became a great practice now for us moving forward. This is another one that we did during that particular this past year. We actually are the healthcare of choice in partnership with the Milwaukee Film Festival, and we have been historically the ones hosting the Minority Health film series. So what you have here on the left-hand side is the Mossville, that When the Great Trees Fall. On the right-hand side is one around the undocumented, especially under Sheriff Arpaio in Arizona. And the reason why I bring this up is because on pre-COVID, this would have been an activity or a series that we would have actually hosted in the community. Upwards of probably 200, 300 people would have shown up for this one. But because we had to actually leverage technology as part of our inclusive strategies here, we're able to make that much more widely available to about upwards of 700-800 people. So we would send them the link to the actual documentary, and then we would actually bring them in and engage them in a dialogue that also features some of our providers there, and other community members for that matter, or community stakeholders, and some of our partners from a nonprofit standpoint. That really led to really great discussions, and people started understanding some of the realities here, or asking questions about their trepidations, right? Or why should I actually go and get vaccinated, right? What is your why? What is it that you could offer that I have not heard yet, right? And one of the things that I think proactively we did, and I think it's part of our secret sauce here, is that we have always come from an acknowledgement perspective, understanding that healthcare has played a role in America, and what has been that role for Froedtert within the greater Milwaukee area. So we're not shying away from acknowledging and being accountable to our issues and how we have contributed to the systemic racism, and certainly the impact that it has had in our community, but also coming in and saying, we know that that's part of the history, but how do we turn the corner? How do we now are able to move forward with proactive steps here to really address fully the needs of our diverse communities? And that, I think, has been part of engaging authentically our community. What you have here is actually our anti-racism banner. And certainly the declaration that we took, as many other healthcare systems. What I will tell you is that this banner here on the right-hand side, now it's a banner that we have in all of our facilities throughout our healthcare system, basically letting our community know what we stand for and against, but also the declaration did not stop in flowery words. It was about also having very specific actions that we were taking and being held accountable to. And so this is actually something that we're extremely proud of. This actually resides also on our external landing page next to our Eradicating Racism and Enhancing Health Equity Plan, which is the 3-year plan for the health network that our Office of Diversity and Inclusion actually leads on behalf of the health network. So again, making sure that the community at large understands where we reside in terms of our efforts and shared accountability. So a couple of recommendations here that I think will be important for all of us to think about and hopefully take into consideration. Promoting culturally and linguistically appropriate data collection, it's critical. Authentic engagement of our diverse communities to co-create those solutions. Again, Dr. James mentioned that in her remarks there as one of the recommendations. Being strategically intentional about addressing disparities and social determinants of health. In our case, again, this is actually hardwired now into who we are and how we do things. I will tell you strategically, we think through an equity first lens. We have built the equity, diversity, inclusion elements into every single goal that we're driving as a healthcare system. So all of our leaders understand what's their line of sight. They also understand what's the accountability. So we're able to actually lead the way from that perspective and model that behavior. And we also have tied compensation to all of our efforts within the health network. Also providing bilingual healthcare workers that could be embedded in the community, the health promoters model or promotoras de salud, that becomes important. And we actually have seen that work extremely well right here in Milwaukee and in one of our rural communities where we have a large Hmong and Hispanic Latino community. So we have been able to respond to some of those needs, again, working with our community-based organizations. Enhancing the collection, analysis, and reporting of standardized Hispanic diversity data elements and variables. And what I will say here is, it's one thing to collect the data. It's a very different thing what you do with that data, how that data is driving decisions within your healthcare system. And I think that that's the piece that has become really important for us as we have collected our REL data here within the healthcare system, and then being mindful of the health literacy implications. Certainly not only, I think for everyone, this will be one of those universal recommendations, but certainly from a Hispanic Latino standpoint, what I will say is, we also have acculturations versus and language proficiency across that continuum. So really understanding the community that we serve and always coming in from that, and landing in kind of that 4th grade level becomes extremely important for us. We have found a lot of success there in terms of providing that information, again, in a linguistically relevant manner, but at that 4th grade level. So with that, I certainly will turn it over to Dr. James.
Thank you so much, Andrés, for that wonderful overview. And I'm seeing a couple of comments in the chat, and I'm sure we will get to those and that tease up our next presenter, I think, who may talk about that, but we will also talk about that in the discussion. So please keep those comments coming. And with that, I'm going to turn it over to Dr. Winston Wong.
Well, thank you, Dr. James, and thank you, Andrés, for a great overview. It always strikes me that when I hear the narrative of other communities, there's actually so many similarities between the communities of color. And I'm sure this audience will appreciate the topics that I'll raise in respect to that. I don't have a PowerPoint, so it is my job to engage you using my voice, my storytelling, and my picture of myself in my living room here in San Francisco, California. So it's a challenge for both me and you, I guess. But I will say that I serve as the chair and acting CEO of the National Council of Asian Pacific Islander Physicians. It's a national organization that was organized 10 years ago, really to support clinicians who serve immigrant, low-income, Asian American and Pacific Islander communities across the country. I think what I want to stress here with regards to my few minutes of presentation is the critical issue of perception and narrative where it comes to Asian Americans, Native Hawaiians, and Pacific Islanders. And I think as Andrés even touched, the nature of these labels continues to change. And it really has to do with our national dialogue around race and nationality. So for example, if I raise to you, and you can think about this for a second, when I say Native Hawaiians and Pacific Islanders in the same phrase as Asian Americans, what do you think of? Just think about that. So some of us probably feel pretty familiar with the question of how we understand Native Hawaiians. I was just in Hawaii last week. In fact, there continues to be about 50 to 60,000 Native Hawaiian citizens that are of Native Hawaiian direct family heritage on the islands. With regards to Pacific Islanders, how do people understand that category? Let me pose that to you. Some of you may be thinking about individuals that are of Samoan descent or Tongan descent. But if I raise to you the Micronesian population, the people from the Marshall Islands, the Chamorro from Guam, the people from Saipan, the people from various parts of the South Pacific, that may not come so readily to you. And I think that's part of the challenge we have with regards to talking about Asian Americans, Pacific Islanders, and Native Hawaiians, is that the category is actually quite broad. It's broad in terms of referencing a group and population of different nations, national origins, different languages, certainly, and different cultural backgrounds. The interesting aspect of this particular label, though, is that in my thinking, it really is what America is all about. And what do I mean by saying that when we use the Asian American, Native Hawaiian, Pacific Islander category, that it's representative of the United States? Well, I do that a bit rhetorically because the sad fact is that Asian Americans and Native Hawaiians and Pacific Islanders are persistently characterized as being outsiders of the United States, people who are perpetual foreigners or who have been marginalized in terms of the mainstream of American life. But in fact, that could be maybe the farthest from the truth. And this is where the perception and the narrative really comes into play. And let me pose a few polemical questions to you. If you think about the population of the United States and what we have experienced as a total people, and the trauma and the challenges and the victories that we've achieved as American people, I think you find that actually across the Asian American, Native Hawaiian, Pacific Islander diaspora. So for example, immigration. Immigration, as far as Asian Americans are concerned, is a big part of our community. Upwards to 60+% of individuals who identify themselves as Asian American were actually born outside of America. And thus, immigrant life is part of what a large part of our community experiences. But also, as part of the Asian American, Native Hawaiian, Pacific Islander designation, we have families that have originated as part of their life in America going back to 200 years ago. And we also have individuals who have come to the United States in the last 2 or 3 years. So this is actually true of almost every aspect of American culture with regards to looking at our roots as recent or past generation immigrants. Now you may say, well, of Native Hawaiians or excuse me, Native Americans and Alaska Natives. Of course, they are the indigenous peoples of Northern America. But certainly that's true of Native Hawaiians, having been part of the islands of Hawaii for at least 10,000 years with the migration of Polynesians to that island. So that aspect of being native to the soil is also part of the understanding of what it means to be Asian American, Native Hawaiian, and Pacific Islander. The other aspect that's similar is that if you look at intergenerational trauma, i.e. the trauma that many of our communities have faced, whether it was enforced enslavement, whether it was the the forcing of taking people off their land as the American Indian and Native American population face. That's actually true of the Asian American, Native Hawaiian, Pacific Islander community as well. Because as you know, in Hawaii, there continues to be the sorrow of Native Hawaiians of seeing their islands being annexed by the United States in what they consider an imperialist takeover. Likewise, when 300,000 Japanese Americans were interned in the Western United States, they were forcibly taken out of their homes, moved to places like Utah, rural Utah, California, Wyoming, etc., thousands of miles away from their home and told to leave everything behind, including their farms, their small businesses that they had established over a generation or so. So that part of being forced off the land, etc., intergenerational trauma continues to be part of the Asian American experience. I have to say, as a child growing up to immigrant parents in San Francisco, there are two very personal recollections that I didn't realize was actually a part of this intergenerational trauma. Number one, I had a number of Japanese American friends that were my age. We were just little kids, and they would reference the fact that their parents had come from the camps, a few years ago, and now we're settling back into San Francisco. Coming into the camps was a natural phrase that was used during the 1960s. And it didn't really impact me until I thought about it later when I learned about Asian American history, that coming back from the camps was a traumatic event with regards to my Japanese American friends. Similarly, when I grew up as a child, it was common vernacular in the Chinese American community to say something like, well, your name is Winston Wong, but what's your real last name? Is it Wong? Which seems like an odd question. But as it turns out, with regards to Chinese American history, Chinese were the first nationality to be effectively barred from immigrating into the United States. And based upon that, many families immigrated to the United States, claiming to have been the children of previous people who had settled in the United States and thus claimed citizenship. So we had to adopt false names. And many of my relatives had different names that subsequently changed when I was a child. And I didn't understand, how come you were a Lee yesterday and today you're a Fong? And it was all the recovery with regards to the historical trauma, with regards to being barred from becoming part of the full American experiment. So I just mentioned those things because, as I said at the beginning, the narrative is so important with regards to how to understand what has happened to issues around health disparities and health equity with regards to Asian Americans. Our perception of who we see is so much different from perhaps the real history and the narrative that exists. So just to switch over a little bit more to the healthcare aspects of this, what does this mean? Well, Cara and Andrés mentioned the social determinants of health, which we all know has to do with the education you receive, the income level, the neighborhoods you grew up in, the amount of support you received as a child, as a family. With regards to the Asian American, Native Hawaiian, Pacific Islander population, and I believe Dr. James and I worked on a workshop, in fact, on this topic. is I think it's important to consider immigration as a social determinant of health. And what do I mean by that? Is because if 60% of the population identifies as, first generation Americans, then that's got to impact your experience of growing up and experiencing what it means to be a full and productive citizen in the United States. Sometimes it's a good thing in terms of understanding the opportunity in the United States and the challenges that our families have to face, the sacrifices that our families have to face, but sometimes it's traumatic. Being the immigrant from a war-torn country, for example, and having to go into a school of individuals that don't have the understanding of where Vietnam is, or not understanding that when you bring paper back home from school, that your parents don't really read much English to understand what the instructions are, or having problems with understanding that you live in a household that has grandma, great grandma, and your cousins living in the same domicile. This is the aspect of really understanding that immigration plays a big part in terms of the formation of what your health trajectory is going to be. I think the obvious things in terms of language comes into play. It was mentioned, I think, by Andrés that's a big factor in the Hispanic Latino experience. I will say that when you looked at the statistics with regards to health equity among Asian Americans, Native Hawaiians, upwards to 40% of the Asian American population did not use English as their first language. Certainly not necessarily in terms of using their in terms of healthcare encounters. Secondly, that if you look at the percentage of Asian Americans that identified a primary care provider, fewer than 60% could say, this is my physician or nurse practitioner or clinician that I see for regular care. In other words, they had no regular care, despite maybe having insurance. The other thing I want to mention is with regards to health equity and disparities, is that in the Asian American, Native Hawaiian, Pacific Islander community, we have disparities within the group. So as Dr. James showed earlier, if you look at some indices, it suggests, for example, I think she showed life expectancy, that Asian Americans have a higher life expectancy than most of the other groups. But when you, and I know Dr. James knows this, but if you dissect that large category of Asian Americans into respective subgroups, Southeast Asians, Cambodian, Vietnamese, Hmong, certainly Pacific Islanders, Samoan, Tongan, Marshallese, Micronesians, you see a much different picture. And instead of a bell curve that you might see in terms of where the median is high and that you just have, at the outskirts of the bell curve, 8 to 10% of people who are outliers. In fact, there's kind of a double crested curve through most of health indicators in the Asian American, Native Hawaiian, Pacific Islander population, where you see a hump among certain population groups and another hump with the other population groups. So with regards to certainly Native Hawaiians and Pacific Islanders, the prevalence of diabetes is sky high. It's about 40%, comparable to Native Americans. If you look at the rate of cancer in Asian Americans, it's actually the #1 cause of death, which is unseen in any other population that's broken down ethnically and racially in the United States. If you look at hypertension, that is prevalent to the degree of 60 to 70% of Asian American adults, but our control rates are actually pretty good in the rates of about 80 to 90%. So I just want to underscore again this whole issue of the perception and probably most importantly, the narrative that goes with regards to Asian Americans, Native Hawaiians, Pacific Islanders. I'm running at the end of my time, but I'll be part of the overall discussion, but I just want to make sure that these points are made so that we really understand that the way that racism and discrimination operates in the Asian American community is to basically marginalize the experience of Asian Americans, Native Hawaiians, Pacific Islanders, so that we appear to be on the margins of good things and not recognize that, in fact, we are representative of all the disparities that do exist in the larger body politic. And perhaps we'll have some time later to talk about COVID-19 in relative to our experience as Asian Americans, Native Hawaiians. But I will just end my little presentation on this, that if you look at the mortality rate among nurses of COVID-19, the highest mortality rate was actually among Filipino nurses, nurses of Filipino descent, whereas they're making about 4% of the nursing workforce. They represented 31% of the nursing deaths associated with COVID-19. And that's a little snippet with regards to how something like that escapes the overall national narrative of what it means to be Asian American, Native Hawaiian, and Pacific Islander in this country. Thank you.
Thank you, Winston, for that wonderful remarks. Definitely engaging in without any PowerPoint. And I think, the importance of understanding our history and the history of our fellow Americans can all make us a little bit more humble and compassionate toward each other. Again, please keep the comments coming. We are going to have one more presentation from Dr. Brian Smedley, and then we will pivot to discussion and want to hear from you. So Brian, take it away.
Thank you so much, Dr. James. It's really been a pleasure to hear these really important presentations. So I want to thank my fellow panelists, and I also want to fully endorse what has been said about many different issues, including the need for example, better and more detailed data collection. We can't continue to homogenize populations that are very heterogeneous and diverse within what we consider to be so-called racial groups. We have got to better understand the experience of immigration, issues of intergenerational trauma, and racism. So I've been just so delighted to hear the presentations from my panelists, and I fully endorse what has been said. I wanted to extend the conversation by talking more about racism in particular, because all of our panelists have noted that this is a moment in our history where racism is becoming clearer and more apparent, even though it has been present with us since well before the founding of this country. We are starting to see how racism operates. We saw it through the COVID pandemic. We saw it through the racial injustice and unrest in response to racial inequity in things like policing and our criminal justice systems. What I want to suggest is that we are, as a nation, beginning to come to grips with the fact that racism is not just an interpersonal problem, an interpersonal phenomenon, or a problem of a few bad apples harboring animus toward people of color. Racism is also structural and institutional. We have to understand how racism is embedded in our policies, our practices, our cultural narratives and myths. I think all of our speakers touched on examples of racism embedded in our national narratives and myths about various populations. I want to talk about what I consider to be a root cause of racial and ethnic health inequities, particularly for African Americans and the Latinx population, a structural form of racism, which is residential segregation. Residential segregation is not an accident. We didn't just get here because people choose to live next to people from the same racial or ethnic background. It is, in fact, the result of our history. So I also want to underscore what our panelists have said about the importance of understanding our history to understand how we got here today and the inequities, the racial inequities that we see today. Residential segregation, of course, is a phenomenon that persists as a result of a long history of formal policy and practice, and even more recently, informal policy and practice, because it is illegal to practice housing discrimination. But nonetheless, discrimination persists. Racial residential segregation persists because of our history. And I want to provide a few examples of how this plays out, particularly to harm the health and well-being of people of color. And again, I'm specifically focused on addressing issues for African Americans and the Latinx population. So I'm going to show just a few slides here, and I want to illustrate the role of residential segregation as a root cause of racial and ethnic health inequities, as we have heard from Dr. David Williams. Let me skip ahead in this presentation because I want to focus in the few minutes that I have specifically on the role of residential segregation. Let me start out by acknowledging that, of course, residential segregation is an enduring feature of the American landscape, and we have made progress over many, many years in desegregating many of our communities, but we remain largely a separate and unequal country. The first issue that we need to tackle is this myth that people of color simply choose to live next to each other or are forced to because of economic issues, not being able to afford housing in more affluent neighborhoods, for example. So let's review our history and talk about how we got here. Our history is that federal, state, and local governments at all levels systematically imposed residential segregation throughout much of our nation's history. And if you want to get a really excellent history of residential segregation in the United States, this book, which I'm having a hard time showing you, called The Color of Law by Richard Rothstein, is an excellent brief history of how government established separate and unequal neighborhoods from the start. They did so through things like racial zoning, allowing, for example, racial covenants, restrictive covenants to be attached to homes so that homeowners could not sell to racial or religious minorities. Federal, state, and local governments also purposely cited public housing and low-income housing in already high-poverty neighborhoods, which had the effect of further concentrating poverty and preventing low-income families from being able to benefit from living in neighborhoods that were more mixed economically. Governments also created subsidies for builders to create whites-only suburbs. This was particularly true after World War II, when many returning U.S. veterans took advantage of a number of federal programs for veterans, such as housing programs, to purchase homes in newly developing suburbs. Well, many of those newly developing suburbs were racially exclusive. They were not permitting people of color to purchase homes in those suburbs. So overwhelmingly, returning veterans, white veterans benefited from those federal housing programs. Veterans of color did not benefit to the same degree. Governments also provided tax exemptions for institutions that enforced segregation, and perhaps overlooked but as powerful was the fact that governments looked the other way when there was violent resistance to people of color attempting to integrate previously white neighborhoods. And this has been true throughout much of our nation's history. Many of you have also heard of the term redlining. And I'm going to show an example of where that term comes from. That, of course, refers to the fact that the federal government, for many years, after federal housing programs were established, essentially cut off economic investment in communities of color, highly segregated communities of color. The old Federal Home Ownership Loan Corporation used to color code maps of our metropolitan areas to designate which communities would receive approved federal home mortgage loan backing and which would not. But this issue went beyond simply backing federal home mortgages. They also extended to other kinds of investment, of private capital, choking off investments in those communities that were deemed too risky. Those were neighborhoods that were color-coded red on those old Federal Home Ownership Loan Corporation maps. And so even though that practice is outlawed today, the lasting effects of that policy continue to be felt, particularly in those communities that were redlined 80 years ago. Today, 3 out of 4 neighborhoods that were redlined on government maps continue to struggle economically. Nationally, nearly 2/3 of neighborhoods that were deemed hazardous or too risky in the 1930s are still inhabited mostly by people of color. Cities with more of these neighborhoods that were redlined and had economic investment choked off 80 years ago still today have significantly greater economic inequality than metro areas that were not characterized by that practice. On the flip side, over 90% of neighborhoods that were characterized as best or color-coded green on those old federal maps remain middle to upper income today, and 85% of them remain predominantly white. Now, the problem of residential segregation, as I indicated earlier, has dissipated a bit in the United States. But just to put the US's level of segregation in international context, these are data collected by demographers such as Doug Massey, Jim Fry, and others, comparing several major US cities, the level of segregation found in those cities with the level of segregation found in apartheid-era South Africa in 1991. What these demographers are using here is a measure called the dissimilarity index, which is simply the percentage of two population groups that would need to move to create complete integration in a defined geographic area. So if you look at the bar on the far left, in South Africa in 1991, that country had a dissimilarity index of 90, meaning that 90% of Black and white South Africans would need to move to create complete integration in that country, which of course was the point of apartheid, to keep the races separate. Well, as late as 2010, several major US cities were not far behind the level of segregation found in South Africa. I need to update these data with 2020 census data, but historically we've seen very little improvement in the level of segregation using decennial census data. So if you look at the second bar from the left, this is a level of segregation found in Detroit, Michigan. This is my hometown. In Detroit in 2010, the level of segregation was 85%, meaning that 85% of Black and white Detroiters would need to move to create a completely integrated city of Detroit in 2010. Several major US cities were not far behind that level of segregation. Milwaukee, New York, Chicago, Newark, Cleveland, all of these cities had dissimilarity indices of 80 or higher, or nearly 80 or higher, meaning that 4 out of every 5 Black and white residents of these cities would need to move to create complete integration in those cities. Why am I focused on the issue of segregation? Well, we know from the research of Dr. David Williams, Dr. Rachel Morello-Frosch, many others, that place matters. And Dr. James indicated this at the outset, right? We know that segregation tends to concentrate poverty and exclude and isolate people of color from the mainstream resources needed for success. It's also true that many people of color are more likely to reside in poor neighborhoods regardless of their income level. And I'm going to show you some examples of this in a second. Segregation restricts socioeconomic opportunity by channeling people of color into neighborhoods with constrained avenues for economic mobility, including things like poor quality public schools. Most of you know that over 90% of our K-12 public education dollars come from local tax sources. That means that if you're a city like Detroit with an eroded local tax base, it is very difficult to raise the revenue necessary to provide high quality schools for those children. These are communities with fewer employment opportunities, fewer opportunities for people to borrow money to start a new business, and smaller returns on real estate. Real estate agents, of course, know that location matters. And unfortunately, the issue of segregation is one of the main reasons why we have such a tremendous wealth gap between white people and people of color in the United States. On average, for every dollar of white wealth, African Americans have about a nickel of white wealth. For every dollar of white wealth, the Latinx population has about 6 cents of wealth. Why is that? So much intergenerational wealth in the United States, of course, is the result of real estate and investments in real estate. Recall what I said earlier, that white families were afforded more opportunities to actually purchase homes in desirable neighborhoods, stretching back generations ago. That practice allowed those families to continue to pass along assets to their descendants. That was not as much of an opportunity for people of color because of our policies historically regarding discrimination in the housing market. And it's also true that you could take two identical properties, one in a highly segregated community of color, one in a majority white neighborhood, and of course, all of you know that the value of the home in the predominantly white neighborhood will increase much more rapidly over time than a home in a highly segregated community, thus explaining much of the wealth gap that we see between white families and families of color. We also know that African Americans are 5 times less likely than whites to live in census tracts with a supermarket. In contrast, they are much more likely to live in communities with a high percentage of vendors selling unhealthy products, such as fast food outlets, liquor stores, and convenience stores selling high sugar, high fat, high sodium products. And in some neighborhoods, this is the only source of food that people have access to. Let me give you an example of this. I referenced my hometown of Detroit a few minutes ago. For many years in the 1990s, within the city limits of Detroit, there was not a single grocery store or major supermarket in that city. All of the major grocery store chains had pulled up stakes and moved out to the suburbs, purely an economic decision, but one that had very drastic consequences for predominantly African-American neighborhoods in the city of Detroit, who lost opportunities to get geographically accessible, nutritious food, and instead, the retail food options were overwhelmingly unhealthy. There's more. Black and Latino neighborhoods are less likely to have parks and green spaces than white neighborhoods. They have fewer safe places to jog, bike, or play, fewer gyms, fewer rec centers, fewer swimming pools. The point of these last two bullets is that in the US, we've done a good job of wagging our fingers at people and telling them, you need to eat a nutritious diet, you need to exercise. But we often overlook the neighborhood context and the fact that those healthy behaviors can be often very difficult to adhere to in highly segregated neighborhoods. We know that many in low-income communities and communities of color are more likely to be exposed to environmental health hazards. For example, in 2004, 56% of the people in neighborhoods with commercial hazardous waste facilities were people of color, even though at that time they comprised only about a third of the US population. So people of color are disproportionately impacted by environmental health threats. And then there's the poverty tax. People who live in poor communities often have to pay more for the exact same goods and services as people in wealthier neighborhoods. They pay more for auto loans. They pay more for auto insurance. They pay more for appliances. They pay more in bank fees. And that's if you can find a bank. In many of these highly segregated, high poverty neighborhoods, you cannot find a bank branch at all, which imposes another geographic barrier to the opportunity for economic mobility and health and well-being. Of course, the issue here is neighborhood poverty concentration. And a few years ago, with some collaborators, we did some research to look at who lives in neighborhoods with different levels of poverty concentration. This slide here depicts the share of African Americans, Latinx population, Asian Americans, American Indians, and white Americans living in neighborhoods with different levels of poverty concentration. The area shaded green indicates the share of a particular population that is living in a low poverty census tract. That is, those census tracts where between 0 and 20% of the population are living below the poverty line. If you look at the bar on the far left, you can see that among white Americans, 90% live in low poverty neighborhoods in our nation's metro areas. That's not the case for African Americans, Asian Americans, American Indians, or the Latinx population, all of whom are disproportionately concentrated in medium poverty census tracts where between 20 and 30% of the population lives below the poverty line, or high poverty census tracts where 30% or more of the population lives below the poverty line. Again, here, I wish we had better data to disaggregate and not homogenize these very diverse population groups, but it gives you a sense of the differences in neighborhood conditions where people of color live relative to whites. Now, some of you may say, isn't that to be expected given differences in income and education between different racial and ethnic groups? Well, we can control for that by just looking at the neighborhoods where poor Latinx, African American, and white residents live. So if you look at the set of bars on the far left, looking at families that are equally poor, we see that poor white families are much more likely to live in neighborhoods with a low concentration of poverty than similarly poor African American or Latinx populations. Only about a third of poor African Americans live in low poverty neighborhoods compared to about 40% of the Latinx population. So here we can see that for poor white families, they are much more likely to live in economically advantaged neighborhoods than poor people of color. Again, this is a result of our history, our policies, our practices, our history of discrimination and housing discrimination that continues to this day, channeling people of color into high poverty neighborhoods. You can see that relative to poor whites, poor African American and Latinx populations are much more likely to live in medium and high poverty census tracts. Again, these are families that are equally poor, but their neighborhood experiences vary tremendously, which is another example of why we should never conflate race and social class, because the experience of poverty, these data suggest, is very different for poor white families than it is for poor families of color. Here's an example from Metro Cleveland. For many years, my former organization, the National Collaborative for Health Equity, worked with the Cuyahoga County Place Matters team, focused on raising awareness about the importance of place for health, and in particular, the importance of residential segregation as a root cause of health inequities. As you can see here, we're looking at the various neighborhoods where kids of color and white kids in the Metro Cleveland area tend to live. If you look at the set of bars on the far left, you can see that over 90% of white children in the Metro Cleveland area live in low poverty neighborhoods. Similarly, slightly over 90% of Asian American Pacific Islander children live in low poverty neighborhoods. About 80% of Latinx kids live in these low poverty neighborhoods, compared to only about 37% of poor African American kids. Again, I wish these data were disaggregated a little bit further so we could look at subgroup differences, but it gives you an indication that on average, Black and brown kids are much more likely to live in high poverty neighborhoods in an area like Metro Cleveland relative to white children. Again, you might ask, isn't this just a result of differences in income or education? Well, let's look at that by, again, just looking at those families living below the poverty line. So here we're controlling for differences in income by looking at where poor Black, poor Latinx, poor white, and poor Asian American Pacific Islander children in Metro Cleveland live. If you look at the set of bars on the far left, again, you can see that poor white children are much more advantaged relative to Black and brown kids in Metro Cleveland. Over 70% of poor white kids live in low poverty neighborhoods in Metro Cleveland. Fewer than 1 in 5 poor African American kids, and fewer than 30% of poor Latinx kids in the Cleveland metropolitan area live in low poverty neighborhoods. Those kids are much more likely to be concentrated in medium, high, and extreme poverty census tracts. Again, reflecting our history. Again, we were just delighted to partner with our partner in Cuyahoga County, the Cuyahoga County Place Matters team, and we worked with them to produce this report called History Matters, Understanding the Role of Policy, Race, and Real Estate in Today's Geography of Health Equity and Opportunity in Cuyahoga County. We were very grateful to work with the Kirwan Institute at The Ohio State University, in particular, Jason Reese, there at the Kirwan Institute, but now he's moved on, still at The Ohio State University. But this report really focused in on this issue of history. And here, of course, is an example of one of those old federal home ownership loan corporation maps where they color-coded different neighborhoods based solely on the demographic composition of those neighborhoods. Many of you who are watching this, I'm sure, are familiar with the city of Cleveland today. You will no doubt recognize that many of those communities that were redlined in the 1930s and 40s remain overwhelmingly poor neighborhoods, concentrated with highly segregated, in highly segregated communities in ways that again, have long-lasting effects to this day. I'm going to close out by just suggesting that there are a couple of ways that we can begin to address these problems. We know from the research evidence that there are several factors that we need to consider. First, we need to focus more on prevention, particularly the conditions in which people live, work, play, and study. Place matters importantly for health. Today, still, fewer than 5 cents out of every federal dollar spent on health are spent on prevention. We need to improve that equation by investing much more in prevention so that we can improve community conditions for health. Second, it's clear that we need multiple strategies across many sectors. These are not just problems for healthcare systems or our public health system. COVID has revealed that our underfunding of public health has had deadly consequences. We need to be working in collaboration with the housing sector, transportation, education, and so many different sectors to address health and well-being in all of our policies. And third, we need a sustained investment and a long-term policy agenda. As was suggested earlier, we're not going to solve these in just a matter of a few months or a few years. These problems were created over hundreds of years in this country. So we need a sustained investment, a multi-generational plan that will help us to address the negative consequences, particularly of structural forms of racism. There are two general buckets of policy strategies that I advocate for. One are place-based investments, investing in communities to reduce the concentration of health risks in communities of color, such as environmental health risks, such as vendors selling unhealthy products, and to attract health-enhancing amenities into communities, such as healthy food retail. There are many important examples of local, state, and federal policies that have improved investments in communities in ways that can enhance health, such as improving healthy food retail options. A second bucket of policy strategies are what I call people-based strategies, things like investing in early childhood education. We know from a large body of research, elegant randomized controlled trials, longitudinal studies that show that high quality early childhood education can help inoculate kids against some of the risks that they may experience as a result of living in a low-income family or in a high poverty neighborhood, and increasing housing mobility options. If we know that segregation is a root cause of health inequities, and if we know that our government had an active role in creating separate and unequal neighborhoods, it seems to me that our government has a responsibility to help correct that. And there are a number of housing policies that can incentivize the creation of more mixed income communities through things like using housing vouchers as a health intervention to help people who want to have the opportunity to move out of high poverty neighborhoods and into low poverty neighborhoods with rental assistance that is often afforded by things like Section 8 housing vouchers. Those very same vouchers, of course, can also be used to help people to stay in communities that are receiving the benefits of place-based investments. We know that in many urban communities around the country, inner cities are being revitalized through place-based investments, bringing in amenities that attract higher income families into those communities. Well, the downside of that, of course, is that families that have often been there for generations are being displaced through gentrification. Housing policies can help those families to stay in place and to realize the benefits of those investments in their communities so that they too can have a chance for a healthier life. I'll stop there. I thank you so much for your attention, and I look forward to a really great discussion.
Thank you so much, Brian. And thank you, Brian, Winston, and Andres. I think these were great presentations. We're hearing already in the chat from that as well. And Ron, I'm only sorry that Cheryl couldn't be here to be participating in this. I think she would have enjoyed that conversation as well. We have plenty of time for discussion, so please start to put your questions into the chat. I think, Brian, I'm not sure, but I think the takeaway from your presentation was where you live matters.
Very much.
I think that is, really important. And one of the things that I just want to ground people as well in the conversation, Brian talked a lot about, even within income categories, poverty, when we look at, we still see some of those racial and ethnic disparities. And we throw around poverty like everybody understands what that means. And I want to just set the stage and say that the current federal poverty level for an individual is $12,880. So if you make $13,000, when you're looking at the data for poverty, you're not counted in that data. And for a couple, we're talking about $17,420. So it's not a lot of money that we're talking about. And there are a lot of people, when we look at what's happening, food access, housing, all of those things that are really kind of struggling in this moment. But I want to just kind of say that because we talk about that, but I don't think we always understand, again, what we're saying with that. So I just have so many places I want to go with the conversation, but I think that, in this moment, Brian and Winston, I know you longest in terms of the work that you've been doing, and Andres, I'm excited about the work that you're doing, but there have been people who have been tackling these issues for years and decades. We, sort of three of us at least were a little younger when we first met and kind of engaging on some of these issues, and are a little grayer now. And I just want to get from each of you your perspective on, what do we need to be doing now that maybe we haven't done in the past, or that we need to expand on to make sure that we're making the most of this moment and advancing health equity?
Well, Cara, let me just offer some thoughts. And thank you, Brian, for a great presentation as always. For one thing, Cara and Brian, I know we share that the discussion of health disparities started about 25 years ago. I'm actually thankful that we've gone beyond health disparities, because as you know, back then we would identify certain clinical outcomes that we thought were disparate, for lack of a better word, across different racial populations. And we advanced that discussion collectively as public health leaders, as communities, to say it's not just about differences, it's about actual opportunity to achieve better health for everybody, i.e. health equity, which I think, again, is an advancement. Now, I think what was introduced today between us three speakers is the critical feature of social determinants of health. But I'm actually feeling like that is also not the end game. For one thing, I think we need to be much more pointed to say there are social determinants of inequity, not just social determinants of health. And to Brian's point, and I'm sure also Andrés' point, we have to be intentional about addressing issues about what replicates inequity, not only in real time, but intergenerationally. And then also we have to factor in and understand the totality of structural racism as it equates to the social determinants of inequity. So I think that's kind of the next stage of discussion, and to take purposeful, intentional steps. One last thing I think we have to do is, as with, things were precipitated once again by the Breonna Taylor and George Floyd murders, it also has revealed these deep chasms between different groups in our country. And also it has exposed wounds with regards to the lack of interracial discussion that needs to happen across not just white and people of color, but even within communities of color. So I think those are some things that we have to do as public health individuals to kind of really try to see if we can take some responsibility and accountability for those discussions.
Thank you. Brian, Andrés?
Go ahead, Brian.
Yeah, I love what Dr. Wong said. I think that's exactly right, that we've not been willing to have the tough conversations and to understand how racism hurts everybody in this country. I think, we've made some intermittent progress here and there toward advancing health equity, but I think we've not been comprehensive in our approach. And I think that what's missing are conversations about the structures and systems that perpetuate inequality in ways that manifests in health inequities. What our friend Daniel Dawes calls the political determinants of health, right? Policies, practices, laws that have created an uneven playing field and that we have yet to correct. I think we've got to come to grips with the fact that we need comprehensive strategies, not just around health literacy or health behavior, although those are important, not just around cultural competency and access to needed care, although that too is critically important. We've got to be comprehensive in addressing these problems. For example, we can have the best health care in the world, which some believe we have, but arguably we don't. But if residential segregation persists and differences in community conditions for health, all of the best health care in the world will not eliminate those inequities, unjust differences in health status, as Winston was pointing out. So I'm excited about the potential to move the conversation forward in a more comprehensive direction. What will be needed now is the political will to put a Marshall Plan in place so that we can improve opportunities for health for everybody.
Great points. I echo my two panelists here. Let me add a couple of other things that I think are going to be really important, and I certainly will speak on behalf of our healthcare system here. So one of the things, and I mentioned this quickly, I think from a systemic standpoint, is that acknowledgement, right? And having that accountability and transparency. And one of the things that I love about our CEO is how vulnerable she is and authentic coming to the community as a white leader, as a female leader, and saying, hey, I know we have not gotten this one right historically, but we are acknowledging, right? And so it starts with that acknowledgement, and then that gives you the ability to start gaining that trust and opening those communications lines with your community. I think that coupled with a number of other key factors that I think are going to be critical. So one of them will be, I think that there's, certainly some room for policy changes that I believe that have to happen. So for example, are we going to provide universal Medicaid for everyone, irrespective of your citizenship? Are we committed to that, right? To start closing some of these gaps and some of these disparities and issues that we continue to confront in our communities. Our payers are going to start requesting this. I, sat on the Institute for Diversity and Health Equity under the American Hospital Association. And remember, there were a couple of plans, so a couple of the payers that were early adopters in starting to go down that path. And certainly they were working with a couple of the healthcare systems and really building that as part of the non-negotiables in the contracts. Is that an opportunity to start moving in that direction, right? I think there has to be greater accountability and transparency around that. And then one more thing that I think it's going to be important for us to address, and certainly I think we all maybe mentioned it, or referenced it, but I think it's going to be important to call it out here is, I think through the pandemic, one of the things that we have learned is also the great digital divide that exists in our communities of color. And I wonder, at what point do our healthcare systems, right? And I think again, partnering with policymakers and the federal government here, do we start paying attention to the algorithmic biases and the issues that this is part of the new frontier that I think we all are wrestling with. And unless we get, we get this one right, it's going to continue to exacerbate some of the historical things that have been mentioned here. And so I think it's going to be an important one for us to address. I'm starting to get kind of my arms around that and working with our Chief Innovation Officer and our Chief Medical Officer around those things, because unfortunately we have learned that even with the best of intentions for our healthcare system, as we rolled out a number of strategies on our virtual care platform, we were not cognizant of a couple of those algorithmic biases, impactful issues. So I think this is one where, as we think about it moving forward, it's going to become one of those new frontier issues for us.
Thank you. So I want to go back to one of the earlier points in the chat, and I'm going to share a resource as I'm asking the question. But we start, all of this starts with the data. And if we don't measure it, we can't improve it. And we've talked about, and each of you have talked about the fact that we have, put myself on mute, broad racial and ethnic categories. But within that, there is a lot of heterogeneity that is represented and sometimes not counted. And so we have places where we need more data and other opportunities. So maybe we could talk about a little bit of how do we improve our data, and for specifically those in terms of the undercount of certain communities, immigrants and refugees, what suggestions might we have for improving that to be able to tell the better story? And I think about, the latest data on the census is showing that there are undercounts, not surprisingly, in communities of color. But how do we get better data?
Well, I'm not the data scientist. I probably look at Brian for that. But I will say this, the heterogeneity of our different communities continues to increase. And as I've advocated with regards to the Asian Pacific Islander Native Hawaiian diaspora to further disaggregation, I make that argument not just for the API Native Hawaiian community, but I think it's actually true of almost every community. I mean, I think, for example, this category Black, and I don't want to be out of, beyond my guardrails, but I do think that the African American population in the United States is continuing to be more heterogeneous than previously imagined. And I think it's somewhat a fallacy to say that we don't have the science to dig deeper and to disaggregate more completely. With all the advances, dare say controversy around using different data sets, even artificial intelligence and algorithms, I think it's within our capacity to look at real important differences within these broad categories and to be able to be nuanced around the methodology and the science. So I'm banking on scientists like Brian, as well as maybe some mathematicians, to really be able to say, these are pretty solidly statistically significant, but at the same time, there's got to be political will to say that that's important to do. And I think that's the Asian American, Native Hawaiian, Pacific Islander population has been at the tip of the spear as far as the political will, because there's been too much retort to our community to say your numbers don't matter because they're too small. If you talk to a Tongan population and say your population is too small to count, and that upwards to 15% of your adult population has been suffering from mortality from COVID-19, that's not a legitimate reason to say you're not to be counted. So I'll defer also to Andrés and Brian with regards to kind of how they think this could be.
Yeah, I'll give you, Dr. James, I'll give you a practical solution that has proven to be very helpful to us here, which was, as we looked at, certainly enhancing our EMR, and we use Epic as a healthcare system, and working within that ecosystem, including some with our federally qualified health centers, to ensure that we were able to communicate and share data between the healthcare systems and certainly with our safety nets here. One of the things that I remember became crucial for us here was really the ability to create an inclusive enterprise analytics platform. And so I remember sitting around with our chief data analytics officer and saying, show me what are the fields right now that exist for us to be able to stratify the data. And other than race and a few ethnicity fields, that was about it. And so, we had to actually go back and forth and continue to obviously push the envelope here to request that we would be able to actually to build that. We were effective. I mean, it took a lot of time, a lot of persistence on our part, but again, it was the right thing to do. If we are committed to this work, then there has to be that political will, right, and commitment to our communities of color. So now we not only have racial and ethnic breakdowns, but we also looked at gender identity, sexual orientation, ability, disability, military, veteran status. We even looked at social determinants of health. And so we are able now to stratify the data all the way down to zip codes to ensure that any community that we're looking at, we can actually go to that level and then stratify the data. Even within, right, our communities of color, right, understanding that none of us are monolithic, to understand what are the differences that even within the Black African American community, within that zip code, are we seeing? Is there a difference in gender between males and females, right? Is it generationally? So I think that there's an opportunity for us to continue to do this work or to move forward in that manner. But again, I think to Dr. Wong's point earlier, it requires political will. Are we willing to do that? And if so, then, are we going to actually push the envelope? And I think that oftentimes that's where things unfortunately stop. And we have decided to move the dial in the right direction there. Has it solved all the issues? Absolutely not. But I think it was a great step forward for us in the greater Milwaukee community to start addressing some of the issues that we have had with data collection and data integrity, to really tell us the right story, and then allowing the data to drive some of the decisions that have been made here.
That's such a great example, Andrés. Every health system should do what you all are doing. There are a number of things that you said which are so important. One, our data need to capture multiple identities, not just race, ethnicity, right? We need to know sexual orientation, gender identity, immigration status, languages spoken at home. All of these dimensions are important for us to know, in addition to being able to collect data at more refined levels, not just these broad racial categories, which make little sense outside of the US context, and which frankly, disadvantage our ability to really target interventions toward specific communities. One of the things that I've been deeply troubled by, particularly during COVID, was the share of missing data coming from states about who was getting infected, who was hospitalized, who was getting tested, who was getting vaccinations. The missing data arises for two reasons, in my view. One, the people collecting the data often don't understand the importance of this kind of data collection and have not been properly trained as to how to best collect the data through self-report. But it's also true that at the other end, people, when asked about race, ethnicity, or other identities, they are suspicious in many cases, particularly for communities of color, where these data have been used in inappropriate ways to disadvantage communities of color. So we need to educate both the folks at the administrative end collecting the data, as well as the people providing the data, that these data are critically important. It was particularly true during COVID with the share of missing data. It helps all of us if we all provide and collect comprehensive data so we know how to target our interventions. And that ultimately is such a key function of public health. It keeps us healthy if we do data collection right. And even though data collection doesn't seem like a sexy issue, it really does amount to that.
Thank you. I am a data nerd at heart. I will admit it freely. And you know, Brian, you talk about COVID, and we are still missing, data for about 40% of the vaccinations and those getting tested. And so, each community has experienced COVID a little bit differently. And there are some things that are common across it, but also a little unique. And I'm wondering if you could each, from your perspective, speak to some of the unique experiences that communities of color have had during COVID, and how the disparities have been overlaid and intersecting with that. And then I am going to pivot a little bit to pick up sort of the where do we go from here in our next spaces. But maybe starting with, what has that experience looked like within these communities?
One thing that I would just highlight quickly is that COVID had so many collateral consequences. And this is true of many pandemics, right? When pandemics hit, people become fearful, they become anxious, they become, we kind of fall back to that reptilian brain. And unfortunately, it resulted in social consequences, such as the rise in hate crimes, verbal and physical assaults against the Asian American community. This is one of the collateral consequences, but I'd also submit that it's part of the reason why the US fared so poorly during COVID, is that the pre-existing racism began to tear at our social fabric, as it always has, leading to distrust. At one point during the pandemic, with about 6% of the world's population, the US had over 20% of the world's mortality due to COVID. Why? And again, there are some who would argue that we have the best healthcare system in the world, certainly the most expensive and the most inefficient, and certainly not the best. But again, division and distrust that has emerged from COVID, I think, has been a tremendous disservice, and it in itself is a public health crisis.
Well, Cara, I mentioned the statistic with regards to Filipino nurses being at the brunt of the nursing mortality rates for COVID-19. And there's a very interesting story behind that. For one, is to surface the fact that Asian Americans play a really critical role in terms of the healthcare workforce and at the front lines, literally. And the other aspect of this too, and I've talked to the Filipino Nurses Association in North America, there are specific agreements and covenants between Filipino nursing graduates in the Philippines to come to certain underserved hospitals throughout our country under specific labor laws. So we've effectively either exploited, if you will, or taken advantage of people wanting to become part of the United States, and then put people at risk for additional danger in front of COVID-19. Of course, Brian mentioned the hate crimes that I would dare say was a dog whistle from some of our most important leaders in our country, which unfortunately really has fueled like an 80% increase in hate crimes towards Asian Americans and Native Hawaiians and Pacific Islanders. The other unique aspect to this is that it exposed that Asian Americans, Pacific Islanders, Native Hawaiians, we play a specific role in the service sector. So contrary to the narrative that suggests that Asian Americans are high-tech workers, professionals, in fact, we have enclaves of Micronesians that are the labor force for poultry farms and slaughterhouses in Arkansas and in Ohio and in Kentucky that suffered some of the worst rates of COVID-19 mortality. In Northwest Arkansas, the #1 group of Arkansas residents that were dying of COVID-19 were of Marshallese descent. And no one would have known that if it were not for the fact that some of our activists were really trying to make this known at a national level. So I think this is representative of the fact that a lot of our story has been masked by a prevailing narrative that does not do our country service in terms of really uncovering what are the racial dynamics with regards to COVID-19.
Yeah, I'll just add a couple of other comments. And I know I referenced during my presentation that a third of our Hispanic Latino community here has been impacted by COVID. So a couple of things there. Number one, and I remember early on having some discussions primarily with our federally qualified health centers and some of our community-based organizations where everyone was scrambling to get information from trusted sources. And unfortunately, there was a delay in even the federal government of recognizing the need to have that information available to our communities of color that are certainly English language learners. So that is an issue. I'm not sure that we have resolved that issue. I think that we're cognizant of that particular issue. And I think that some of our states and local governments and health systems are being very proactive about that, understanding that this is our new reality. So how do we use this as a lesson learned and a path forward for our communities of color? So I would say that that's one of the major issues. Number two, I know that in working with a lot of our community-based organizations, one of the things that came up was the fear of those who are undocumented on whether they could actually go and get tested or whether they could actually go and get vaccinated, because there were actually a number of certainly comments made or rumors going in the community that ICE was going to be actually paying attention to that, and that they would be co-located in those particular sites. So that became, created a major fear factor and distrust in our community. And to this date, I will tell you, there's a number of people that have never gotten tested, that are not vaccinated, because they do not trust that if they go to their local medical home, that they will not be certainly screened through that particular lens. So I think that that's a major issue. I would say vaccine allocations was a major issue in our community. I know that a number of our federally qualified health centers, who are obviously that safety net, were not receiving. Actually, it was the health systems here that had to advocate at the state level and the federal government, so to ensure that they were getting an allocation. So that's a major, I think, faux pas that was made, and I'm hoping that we have learned from that particular issue, and that will not repeat itself here from a historical standpoint. I think that the whole messaging around social distancing and wearing masks and certainly sanitizing your hands or washing your hands. I will tell you, within our Latino community, I remember having discussions again with some of our community-based organizations, and they kept on bringing two key themes. Number one was, do people realize that a lot of our community work in customer-facing roles, that either they go to work or they do not get paid, and even those, right, who are undocumented. So, this was, right, the impact economically, and I'm not sure that anyone realized that people were thinking through that particular lens, but then B, understanding that perhaps social distancing, especially if you have to rely on public transportation and you're working in facilities where that might not be optimal, or perhaps you actually live in a home where there's multiple families that are living there, right? Because economically, that's the only way that they're able to actually survive in our communities of color. So I think that understanding some of those realities and really customizing or tailoring our messages or what would be practical in those situations became extremely important, and became actually our ability to save lives at the end of the day. So I think that became important. And then the last point that I'll make here is, and I know I referenced this during my presentation, was the need not only to provide culturally and linguistically relevant information, but also in terms of the response rate of that. And so I think as we engage with our community, and this now has become part of our community conversations with different diverse communities here, I think that the bright spot for us was the creation of those public service announcements. And again, by the way, and I should have referenced this, these public service announcements were not made by our chief medical officer or any sort of health authority here in the region. We chose to go with the feedback from our community, which was get a trusted source from the community who can deliver that message. And so we use, for example, for the African-American one, G. Smith from G Clippers. He's the owner of a really well-known barbershop here. Actually, he's a barbershop of our NBA champions, the Milwaukee Bucks here. And so he actually now has created a small clinic in the back of his of the barbershop, where we're going in and we're providing education, and we're actually doing some of the health screenings as well. So again, it shows, right, the creativity and innovation, but it was something that we needed to rely on our community to actually start educating us and to bring us along. And so he was extremely compelling through that process, and he was able to articulate his own why, and then certainly put a little bit of that call to action. And we started seeing that the community, the African-American community, started responding to that, to the messaging there and that call to action. Similarly, the Hispanic Latino community did the same thing. Again, we use a trusted source there. It was actually a retired community-based leader here who's highly regarded, and he was able to actually provide his own why. Again, we did all of that within the community. So it was not actually done within a Froedtert premise. We went to the community. We actually ended up recording all of that in the community. And again, making sure that people understood the why, but also looked at some of the video, and they were able to recognize that this actually happened within the community, that this was actually something being done by the community for the community. So again, to me, those are things that became really important for us through COVID, and our hope is that we'll be able to continue to amplify that moving forward.
Thank you. So I have a couple more questions, and again, if anyone has anyone. Winston, you talked a lot in your presentation, in your remarks, about narrative and the importance of narrative. And I think that in some of the comments that we've had in the conversation after the presentations, talked about the fact that we are a pretty divided country right now, and that our perceptions and narrative, and I know that Wanda shared the resource, for those of you who may have seen the AMC and WMC and the American Medical Association produced a guide around language and narrative and concepts, and it's really a great document in thinking about health equity. But from your perspectives, all of you, like, how do we change the narrative to, I think, really garner some of the support that we need to really extend the window of opportunity, one, but also the support, because you've each mentioned the political will to make these changes. And part of that is pressure that they get, because we'd like to think they do things just because it's the right thing to do, but that doesn't always happen. So how do we change the narrative move forward?
Wow, that's a that we really should have a conference on that. But I will say, just since you invited me to comment about my talking about narrative, I do think that part of our narrative, and to I think Brian's earlier point, and I also saw an article that came out just yesterday with regards to de facto segregation and ghettoization of our country, that this is a detriment to the future of our country. Not just if you're, you know, not if you're just altruistic, but also if you're thinking about the future and vibrancy of our economic situation, our security, our safety, our unity, our standing in the global economy and our global political standing. We need to be able to say that we are standing against structural issues that prevent us from building a better country that goes across racial lines. And that is not about a black or white position. It's about what our country needs to do to realize its full potential. And then I do think that within the different BIPOC, the Black, Indian, people of color communities, is to pull the thread through in terms of all the structural issues of racism, colonialism that impacted all of our country, all of our communities, and have also infected our communities with much more division than there should be. I think that the level of interaction between communities of color continues to evolve, but it needs to continue to improve, frankly. There needs to be more honest conversation about how we support each other rather than how we fight for each of our individual communities. I feel really strongly about this. I have to say that, I've been trying to really be as informed as I can about other communities aside from the Asian American community, because it ain't going to do me no good just to say, Asian Americans need this without fully understanding dimensions of structural racism as it permeates every aspect of our life. So that's part of the narrative, is to stand up and call out all these different aspects across our communities.
Thank you. That is well said. Well said. So my last two questions for you guys, and if we don't have any others, and I will turn it back over to Stephanie, who can kind of wrap us up. But we've seen in this moment really a lot of people from a lot of different sectors stepping into this space and trying to address some of the issues. And there's a lot of activity and attention. I'm really heartened by the fact that the New York Fed actually, for their priorities, has laid out climate, wealth building and household financial well-being, and health and health equity. So I think there's a great opportunity to engage across sectors in ways that we may not have before, or strengthen partnerships that already exist in this space. And we talk about that policy agenda that needs to happen. So this is kind of a two-part question for you, but one, how do we build more of those coalitions and work across sectors, become a little bit more, as I like to say, bilingual in how we talk to business or education, because the way they talk about health is not the way that we in the health sector do, but how do we forge some of those, and what should be our priorities from a policy perspective to really break down some of these structures that we're seeing that are contributing to our inequities?
I'll take a stab at that. First, I think that what Dr. Wong just laid out is exactly the argument. That's the narrative, that our fates are intertwined. And so this is about your enlightened self-interest, no matter who you are, no matter what sector you work in. We are all ultimately hurt by the persistence of health inequities. It has implications for our international competitiveness. It has implications for our workforce and our ability to be as productive as possible. And the cost of allowing these inequities to persist goes beyond human lives. It affects our economy. It drains our economy in ways that hurt everybody. One of the things that I would like to see is government modeling the kind of intersectoral collaboration that's necessary. A number of states, for example, understanding that advancing health equity requires that various departments and agencies work together, have created interagency collaboratives. Washington State did this, for example, and the Biden administration is looking at this, so that when we're talking about health equity, we don't just have health departments at the table, but we also have departments of transportation, education, housing, the environment, et cetera, figuring out how do we align policy in ways that advances equity and ensures that everybody has an opportunity for a healthy life. That's an essential function for government, and government can effectively model that so that our private sector, faith leaders, civic leaders, business leaders can begin to get it, that there is a responsibility for their leadership as well in this work. We can't do it alone.
Andrés, you're on mute.
Sorry, I will reiterate one of the points that have been made by obviously my two fellow panelists here, which is it's about partnerships. And one of the things that I have learned here is the power of the private not-for-profit partnerships that have been forged to address this. And that gets me to the point about siloing or silos that have been created. And historically, we know that each organization, right, or organizations and entities look at what's in it for us or what's our strategy. But we need to become altruistic and really say, hey, if we can put our community, right, we need to become community centric in our approach. Then if we put community first, I think that's paramount to this discussion. And then we can actually decide and deliberate on what will those partnerships look like. But we need to actually come from that perspective versus actually approaching it through our lens of being, healthcare centric or corporate centric from that perspective. And so to me, that has been one of the keys here to be able to do that. Actually, there's a great model from a workforce development standpoint. And Dr. James, you mentioned that in terms of workforce development in one of your slides. We have been able to do that actually. And I say that we're competitive here. So on one side, right, all the healthcare systems are competing for the patients. And you could argue, right, that in this great resignation, even though I think it's the great opportunity as well for those of us who have become an inclusive workplace of choice, we should be able to actually realize and use that as a key differentiator for us. One of the things that we have done there is really partner as healthcare systems and really put Milwaukee on the map as a hub for healthcare in general. So we're doing that. And one of the things that we have said is not only attracting talent from elsewhere, but it's about grooming our own talent here. How are we creating those, pipelines? And so where we know where we have the greatest opportunity, the low-hanging fruit, is in diverse communities. Actually, you look at a state like Wisconsin, we are an aging community. This is a community where people are born here, they grow here, and they grow old here in our state. People don't move necessarily to come to Milwaukee. I'm probably the anomaly in many ways in terms of being a transplant here. But my point there is, the one sector that continues to thrive is our diverse community, whether it's actually the Hispanic Latino community, number one, Hmong, number two, African-American, number three. And so one of the things that we have done is really work through this coalition and say, hey, let's make sure that we're investing in our community. Let's actually expose our children at a very young age, because we know that also that's going to be a key differentiator. If we wait until middle school, they're going to be trailing behind if they have not acquired those STEM skills by then. So that's part, I think, of what has actually worked for us from a partnership perspective. And then there's a whole piece about allyship too. That has to occur in our communities. So this might not be work, right, that we are extremely involved with, right, in some cases, but it's a social determinant of health. And so what we have decided to do is we're going to invest, we're going to become an ally, because we know that if we address and we're investing in some of those interventions and efforts in our community, at the end of the day, it actually will create community and economic vitality. It will create vibrancy. And so again, it's sometimes about understanding that we don't have to be leading. It's about sometimes being behind and supporting those who might be leading those efforts to address those social determinants of health that perhaps might not completely fit within our strategy. So again, it goes back to that political will and commitments that, again, if you're committed to it, then you have to actually invest in those strategies as well.
Thank you. And last question. We are at a moment that is unprecedented at this time, and there's a lot of activity and a lot of interest in this space. And so there are also a lot of things that people are doing. And so for the audience, as well as for you, as you look ahead, sort of this is, again, that's two-part question. So one, what one thing do we need to make sure we do if we don't do anything else so that 5-10 years from now, we're not having the same conversation and that we don't feel like we've squandered this moment? And from the perspective of our participants here, what is the call to action that you would ask them to do to make sure that we all take a collective step towards advancing health equity?
Such a great question, and that makes this panel very fun. I think we all have a role to play, I guess has been my bottom line message. We all have a role to play. No matter what sector you work in, we all can do a number of things. One, engage with your elected officials at all levels. Get to know them, talk to them about your interests, share your expertise. We in public health in particular have been too shy about sharing what we know from our evidence base about what works. I think we also need to be working in our communities. We know that communities that have high levels of social cohesion and what they call collective efficacy, which is simply the ability of a community to work together to solve its problems and get things done, that's so critically important. I think that's one of the reasons why the US has fared so poorly during COVID, is because we are not a nation that embraces community and emphasizes collective efficacy, what we can do together. So again, no matter who you are, what sector you work in, we all have a role to play to create cohesive communities that are bound together and that understand that we can come together to solve our challenges.
So Cara, there will be a time that when we look back at the pandemic of COVID-19, we're going to have to come to some reckoning. Whether it was the darkest of times of our country's history with public health, or was it an opportunity to really take some reflection on the heroism that existed across our communities? My point being is we need to make sure that what happened and what is happening with regards to COVID-19 and how it's ravaged every community, not just communities of color, but every community, and the loss of loved ones, that we don't lose those lessons in terms of constructing a better future. And I'm really kind of fearful because sometimes we have short memories to really understand and take some time to look at all the structural, social, political, cultural issues that came into play in terms of why we're here. The second thing I would say, particularly to this audience, is I think we should really advocate, given what we've learned from COVID-19, we need to really invest in a public health structure and a public health workforce that is commensurate with really what the needs are in terms of the death and mortality, morbidity that has been associated with the pandemic, because it's really reviewed how vulnerable we were and have been around a public health menace such as COVID-19. COVID-19 as a virus has no political affinity. It's just a biologic agent that overcame us. So I think those are really two important things to bring forward.
Great points. I'll just we'll add one more, which is building the partnerships in diverse communities. One of the things that has struck me over the last 26 years, and I've lived in a number of communities, and actually I wanted to say to Brian, thanks for the shout out to my own hometown of Cleveland, Ohio. I grew up in Cleveland, Ohio. So Cleveland will always be home from that perspective, was that the ability to create Black and Brown dialogue and partnerships. Unfortunately, one of the issues that I continue to see and we struggle with, and I think Dr. Wong made that point specifically, was that we do not, reach to the other communities, right? And really create that coalition. And that's critical. We need to have more voices. We need to have, certainly all of those diverse voices are on the table. I believe that that's actually how we're going to gain greater power, by sharing the power. And that oftentimes is not happening in our communities, because we have gotten accustomed and conditioned to actually fight for the crumbs, not for the pies, for the slice of the pie, right? So I think that is shifting that mentality and really creating that. And I think the call to action here is, I think everyone, again, and Brian made that statement, which is we all have a role to play. And I actually tell folks, get involved, whether it's in your own organization, maybe it's at the community level. Look for some vehicle, some effort that you can get involved, that you can actually certainly make a difference. And as you do that, continue to grow, continue to build your competencies. And that's what's going to actually continue to build you as an equity ambassador or change agent. I think we need more people involved and engaged in this work. And so to that point, also building the next generation. I'm a bit concerned about the vacuum of leadership that exists and those who are going to come behind us. And I'm not sure that even as I look at in my own organization, and we're now having discussions about succession planning and building that bench strength, that we have the ability to do that tomorrow if a number of leaders actually won the lottery and decided to retire. And so that's a big concern that I see, and a huge gap that we have, but yet a great opportunity for us as well.
Well, Brian, Winston, Andrés, thank you so much. And I want to thank Ron and his colleagues at the Ohio Federation for Health Equity for putting together this conversation. And I want to thank all of you for joining us and sticking with us through these 90 minutes. It's been really interesting, but I think that, my takeaways from this is we need to understand our history and understand how it has gotten us to where we are today, that we need to take ownership of our narrative and our perceptions and change those to be able to build allies and collaborations to tackle those tough issues, that we have more in common than we have different. And that is something that it is hard to hold on to, that when we are continually being presented with opportunities that divide us and messages. We didn't talk about, and could have a whole session on message misinformation, disinformation, misperceptions, and the importance of that. We know that where you live matters, and that we need better data to understand what's going on, and that we can learn about each other to help advance our agenda and tackle those tough issues to get towards achieving a more equitable future for all of us. Again, I'm just really grateful to Andrés, Winston, and Brian for the conversation. And again, for you all who've been sharing resources and questions, and most grateful to Ron and his colleagues at the Ohio Federation for Health Equity for putting this on. And I will stop there and turn it back to Stephanie.
Thank you so much, Dr. James. And thanks so much to all of our panelists for your insights and for your amazing dedication to equity for all of us. Before we hear from Stephen Mamaris with Amgen, I did want to remind everyone to complete the evaluation, which will be sent later. Also, please join us for the second webinar of the series, Racism and its Impact on Communities of Color, on December 7th, 2021, with Dr. David R. Williams from Harvard University. And now we'll hear from Stephen Mamaris from Amgen. Thank you so much.
Thank you, Stephanie, and thank you all for allowing me to join this very distinguished group of speakers and guests. This was an incredibly informative conversation, and one that Amgen was very proud to support. I think there were many messages of optimism throughout the conversation, and I think As we spoke today on a Wednesday afternoon, yesterday evening, we saw candidates of color elected in mayoral positions really at a historic rate. So I think there are some areas of optimism and opportunity to as we continue this conversation, because I know that one of the themes was, whether or not there would be political will to implement some of the suggestions that our speakers provided. My name is Stephen Marmaris. I'm with Amgen's Advocacy Relations team. Amgen is a multinational biotech company that makes medicines that reach millions of people around the globe in approximately 100 countries. We make innovative therapies to treat diseases with disproportionate impact on communities of color, diseases like in the oncology space, cardiovascular, bone health, inflammation, neuroscience, and nephrology. It's been said that we're living in the biocentury, where we've seen incredible innovations that treat and cure our most deadly and debilitating diseases. However, as we've learned and from our presenters here today and discussed, not all individuals are benefiting equally from this medical and scientific progress. Amgen is committed to addressing health inequities in communities of color. We believe this work will only be accomplished by community-level activism and a long-term sustained partnership to support organizations like the Ohio Federation. We are committed to seeing this journey through alongside you. We are not interested in accolades or attention and acknowledgement. We are proud partners. I appreciate this opportunity to say a few words to you, and I wish you all a very successful and fortunate close to the end of the year. Thank you very much.